Good morning, everybody. I am a medical person and talking to a gathering of surgeons on a topic which is purely medical. I'll try and do something that I'm able to express it well enough that you are able to understand and enjoy the talk. The topic immunotherapy in pediatric tumors, the first line is that if I compare it with adults, the role is much less. The points that I will cover in the next 18 minutes or so will be the following. Is cancer an inflammatory disease? The principles of immunotherapy and the targets, the prototype of immunotherapy in pediatric tumors, and is there a poor man's immunotherapy or not? So coming to the first question, is cancer an inflammatory disease? And let me start by saying that one of the models that may be thought of is a Barrett's esophagus, which results in inflammation, and then it goes on to develop into an esophageal adenocarcinoma. So inflammation going into cancer. Likewise, the role of H. pylori and gastric cancer and maltomas again tells you that there is inflammation that can go into cancer. Again, there is a risk of IBD and colorectal carcinoma. Again, the same principle. So just to recapitulate the hallmarks of cancer: sustained proliferative signal, evading growth suppressors, resisting cell death, replicative immortality, inducing angiogenesis, invasive, and metastasis. And to add on to these hallmarks, we have two other things: abnormal metabolic pathways and evasion of the immune system. And what enables all these hallmarks are two things: genome instability and inflammation, once again. So there is a lot of interest nowadays in tumor microenvironment. So the shift is that you actually, not just the cancer cell, you look at what is around the cancer cell. And the classic prototype of this principle is Hodgkin's lymphoma. In Hodgkin's lymphoma, when a pathologist sees a slide, out of 100 cells that will be seen under the microscope, maybe 1 or 2 would be the cancer cell, and 95 or 98% of the cells are inflammatory cells. So if you look at this slide, there is only 1 or 2 cancer cells in the entire slide. The rest all are inflammatory cells. But it is still a tumor. It is still a tumor that can kill when 95% of the cells are inflammatory cells. So the tumor microenvironment can be classified as hot or cold. Hot meaning inflamed. That means there are a lot of infiltrating inflammatory T cells. And cold means that the inflammatory cells are excluded. That means it's an immune desert. I did a search 2 years back: inflammation, cancer, prognosis. I got more than 15,000 articles. I did this search yesterday, and the number of articles were touching 17,500. So that is the relationship of inflammation and cancer. Now, the TCGA has looked at the landscape of cancers, and they've looked at more than 10,000 tumor samples, and they have actually classified tumors as immune responsive and immune resistant. Let me tell you, colorectal cancer, you could have a same tumor with a high high MSI, which means that there is genome instability, and this particular colorectal cancer will respond well to immunotherapy versus that which does not have MSI. Now, you must have, I will introduce another term. tumor mutation burden. If the tumor mutation burden is high, the tumor will respond to immunotherapy. Now, this term will also tell you which tumors are high in mutation burden, environment related. So those who smoke, so lung cancer, classic example of a high tumor mutation burden. Those who chew gutka, tobacco, high tumor mutation burden in the oral cancer. But the pediatric tumors are not due to these influences. They happen de novo. And that's why they have a low tumor mutation burden. So going by that logic, if the tumor mutation burden is low, they will not be immune sensitive. I mean, they will not be sensitive to immunotherapy. So we looked at Ewing sarcoma at our institution. This was a study of more than 800 patients of Ewing sarcoma. And we found that those who have a high TLC end up doing poorly, both for event-free and overall survival. Now, on paper or technically, Ewing sarcoma is a tumor with a low tumor mutation burden, but yet there is impact of neutrophils, inflammation. So based on this, I conclude that inflammation is integral for several cancers and has an impact on treatment. Even tumors which are cold, which are seemingly not having inflammatory cells and not responsive to immunotherapy, I believe that there are targets which we have not identified, which we can target and have immunotherapy in the component of treatment. I will introduce this gentleman to a team of surgeons, and he's a surgeon himself. He was an orthopedic surgeon, William Cooley. In the late 1800s, he was working in the current Memorial Sloan Kettering. And as a lecturer working there, he found that the soft tissue tumors that he was seeing in his clinic, whenever they got infected, some of these tumors disappeared or reduced in size. He was intrigued by this finding. So he started working in the lab, and he is the pioneer of cancer immunotherapy. When he worked in the lab, he discovered a factor which later came to be known as tumor necrosis factor alpha. His name is William Cooley. 10 years back, there was an issue in Science, and the whole issue was just dedicated to cancer immunology and immunotherapy. You would have all encountered, if you do a genome sequence, everything about a tumor, you have a same tumor, same Wilms tumor, or same Ewing sarcoma, you have the whole panel of the genome. Yet two tumors do not behave exactly the same. That's the beauty or interest about medicine. And why would this difference be? We have the 3 E's: elimination, equilibrium, escape. That means there is always a fight between the tumor and the immune system. Whosoever wins, wins the race, wins the battle. That is why the same tumor does not behave the same way in every individual. So what do the tumors do? There are co-stimulatory pathways where the immune system will able to work to kill the tumor. And the tumor, if it has to stay in the body, it will have to down-regulate these pathways. What are immune checkpoints? Immune checkpoints mean that the tumor would up-regulate these pathways and create burden or problem for the immune system to kill the cancer cell. So these are immune checkpoints. And to counter these, we have developed immunotherapy approaches. The approach may be passive, like an anti-tumor antibody, or adoptive cell therapy. Adaptive cell therapy basically means that you use the cancer patient's own lymphocyte, expand it and reinfuse into the patient with cancer. The classic example of that, which is being currently used, is CAR T cell therapy in the management of ALL, myeloma, BNHL, and research is going on to expand this work to the use of solid tumors as well. What targets to choose? So let's say if we have to target a pediatric solid tumor, we want to choose a target that is there in the tumor, ideally, and not anywhere else. Because that way you can just target the tumor cell and not target anything else in the body, and so no side effect. So it has to be there on the cancer cell, not on any other cell. And even if it is there on some other cells in the body, it should be such that even the side effects are minimal. So neuroblastoma, which is the prototype for immunotherapy, the target is GD2. It is present in neuroblastoma, and it is a perfect target to target. And for that, we have an antibody, which is the denutuximab. And there are trials wherein denutuximab in a post-transplant setting has been combined with GM-CSF and interleukin-2 to augment the cell-mediated cytotoxicity of neuroblastoma cells. If you look at these Kaplan-Meier curves, the line above is the one with the denutuximab, and the line below is the one without denutuximab. Clearly, there is a 10 to 15% improvement in survival if you use immunotherapy versus if you do not. Next comes active immunotherapy. Active means you will enhance the T cell function. It's not passive. You are doing something wherein the innate system will start working more. So enhancement of T cell function, introducing vaccines, or you use checkpoint inhibitors. If you look at this interesting cartoon, what it shows is that the antigen presenting cell, this lock is there between B7 and CD28, and this will activate the killing of cells. In a tumor, what they do is they avoid connecting with CD28, and a new marker or a new molecule gets expressed on the T cells so that the antigen presenting cell cannot bind, and hence the cell kill cannot happen. What do humans do? Humans make an antibody against the molecule that has been made by the T cells, and this is called immunotherapy concept or checkpoint inhibitor concept. So this is an example where you have so much tumor of a melanoma, and after use of immunotherapy, it has disappeared. 15 years back, our group published an article saying that metastatic melanoma has an outcome of less than 10%. Today, when a patient comes to me with metastatic melanoma, the outcome of cure is more than 50%. More than 50% chance that a widespread metastatic melanoma can be cured with immunotherapy. So that is the impact of this treatment. Now comes the cost. If I have to use immunotherapy for 1 year as a checkpoint inhibitor, the cost in Indian rupees would be 3.5 to 4.5 million. And the immunotherapy for neuroblastoma, since it's not even being marketed currently and we have to import, it will come to almost 7 million for a body surface area of 1, or maybe 3.5 million for half the body surface area. So that comes to almost 35-40 lakhs, which in general is not affordable for a fair number of people. Do we have a poor man's immunotherapy? That's the last question that I'm going to try and answer. A poor man's immunotherapy. And this answer comes from this instrument, which is a metronome, and those who play music will know this, that it gives a beat at regular intervals. And that is the concept of metronomic therapy. That means you give therapy at frequent intervals. You do not give a drug-free break, and it's at a lower dose. Nowadays, in metronomic chemotherapy, we also use non-anti-cancer drugs, and hence the term is metronomics. So what is the mechanism of action of this mode of therapy? It is believed to be anti-angiogenic and anti-inflammatory as well. Our center did a trial using a combination of thalidomide, celecoxib, cyclophosphamide, and etoposide as an anti-inflammatory regimen in refractory solid tumors. This was published in JAMA Oncology in 2017, and this showed that in non-bone sarcomas, the use of this metronomic therapy improves progression-free survival and overall survival. 3 years later, nowadays in high-risk rhabdomyosarcoma, we use a 1-year maintenance metronomic therapy as a standard therapy these days. In fact, oral metronomic therapy is equivalent to pazopanib in advance of tissue sarcomas as well, and that also we have been able to show from our data. So that was my last slide, the concept of a cheap man's immunotherapy if somebody cannot afford 35, 40, 50 lakhs of rupees. I want to thank the institute where I work, the All India Institute of Medical Sciences, and thank you all for a patient hearing. Thank you so much.